It's a pleasure to have the opportunity to say some words about principles of preeclampsia screening. This is a very important topic, as Magda already told us. And it's not going further. However, I will try. So yes. So the definition is commonly known. We know that this is a multisystemic syndrome which occurs in the second half of pregnancy. And the woman with preeclampsia has a high vascular resistance and blood pressure together with the reduction of plasma volume. The definition of preeclampsia was slightly changed in the last years. This is the definition from 2018 in the lower part of the slide. We know there is always proteinuria, the kidney injury, the liver dysfunction, the low platelet count, and the dysfunction of the whole organism, like neurological complications and uteroplacental dysfunctions. There are many risk factors. We can group it in the two main points, the high risk and the moderate risk. The high risks are more connected with chronic diseases like hypertension before the pregnancy, diabetes, and the others. And the moderate are more connected with obstetrical history, if that's the first pregnancy or multiple, or if there was already history of preeclampsia in the patient's family. So there are many known factors. We can see here on the left side of the graph that the most important is, as I already told you, the hypertension, the chronic hypertension or diabetes. So knowing all risk factors, there was produced the algorithm how to go with the diagnostics and the treatment of the preeclampsia. Here are the NICE guidelines from 2019. So, however, I could finish on this slide, but this is not so simple. Then I will show you some more details how it is to diagnose. So the risk assessment based on these risk factors was insufficient. It was shown in two publications from Ictolides group in ASPRI trial. It was in 2018, and in 2020 in this pre-diagnostic accuracy study was also the results was published. So basing on this, we can go to the combined screening. There are several factors in this screening involved. The maternal, the arterial pressure, the uterine arteries Doppler, and the biochemistry. The main role plays biochemistry with PLGF and receptor for PLGF, so-called split-1, and also we can also use the PAP-A protein. And the pathophysiology of preeclampsia, this is the graph from Lancet from 2003. We see that in normal pregnancy, when there is a lot of PLGF, the vessels will be remodeled and the blood flow increases very rapidly. And so the course of the pregnancy goes normal. There are all normal organ functions and the ratio of split and PLGF is okay. Then when we have the preeclamptic woman, then we do not have enough PLGF, the vessels are not remodeled and the blood flow decreases very fast. So we can see then the consequences in the dysfunction of the whole body of the preeclamptic women. And so then we can call it multi-organ disease with all these problems which I told in the first slide. And of course, in the lab results, we can see this abnormal split-1 and PLGF ratio. The next important publication is from hypertension from 2014. Then it was concentrated on the cutoff values for this split-1 PLGF ratio and usefulness as a diagnostic test for preeclampsia. In the graph from this publication, we can clearly see that the concentration of the split PLGF, so the values of the ratio of these both factors are significantly different in the normal pregnancies, the green boxes from these red boxes, which show the preeclamptic women. And this is also for the early phase, so the early preeclampsia, but also for the late gestational phase, also for the late preeclampsia onset. And the next benchmark in the publication was this publication from 2016 from New England Journal of Medicine about predictive value of this ratio in women which are suspected. So the prediction of the preeclampsia in the women. And the test is very simple. As we can see, if the value of the ratio is over 85, then we can diagnose the preeclampsia already. So it's a quite 100% specific that the woman already has preeclampsia. If there is low value, lower than 38, we can rule out the preeclampsia for the next week. And in the median values that we have to predict it and rule out in the next 4 weeks. And it was confirmed by the studies by Nicolaides. This is results from the study, and we know that PLGF mom is decreased greater, much more when we then have to early deliver the woman because of the preeclampsia, of the worsening course of this preeclampsia. So the performance of the screening is much superior for the preterm form of the preeclampsia than for the late one. The slope of the regression lines also increases with the gestational age. So the performance of the screening improves with the advancing gestational age of the screening. About the receptor, the split one, we can say that it is increased, and the increase in preeclampsia and it increase precedes preeclampsia about 1 month, about 5 weeks. So this is concordant with the results from this New England Journal of Medicine publication, which I showed 3 slides ago. And plasma protein A, the PAP-A protein, it can be also useful in predicting preeclampsia. However, the PLGF is superior to that, so it's maybe easier in the regions or in the countries when the resources are not allowed to have a PLGF test at the term of the first trimester screening at the 12 weeks. The other component of the test, the mean arterial pressure on the right side is listed. How we can do that. It's also very simple method of the biophysical assessment, and the much more sophisticated, the uterine arteries Doppler, already known for everybody, I think, who is who works as obstetrician. You see that the publication is already old, it's 40 years old, from 1983, but the importance is still high. And we can see also here, it's confirmed by the studies in Fetal Medicine Foundation. We know that if there is abnormal trophoblast invasion, then we have insufficient uteroplacental blood flow, then the vascular resistance is increased, and we can detect it already in the first trimester scan at the 12 weeks, and we calculate, of course, the mean PI from the both uterine arteries. So it's shown how we can do that. The proper technique is listed on the right part of the slide. Why is so? So we can see here that in the non-pregnant women, the uterine artery stays very thin, it's very tight, and the resistance of the flow is high. In the normal pregnancy, it decreases very rapidly, and so the resistance drops. And we can see it in this blood flow waveform. And in the preeclamptic women, it stays high because there is no, again, PLGF. It's the uterine arteries, the spiral arteries, and the smaller ones stay very tight, and the resistance is high. And we can see it very clearly in the uterine artery Doppler. So in the summary, we've got a complete test and combined screening where the characteristic of the test is quite good. Even for the fixed detection rate of 80%, we see that we can pick up 1 in 102 is a risk cutoff. And then the test where we use the PLGF, this is in the downline of this table, the accuracy is much more precise or much better than with PAP-A, but of course it's always connected with false positive rate, results of which are false positive. So in conclusion, the first trimester screening for preeclampsia, the preferred biochemical marker is PLGF rather than PAP-A. We can, of course, achieve the same detection rate with PAP-A, but then we have a high screen positive rate, and it was published in these 2 publications on the right side of the slide. We've got our guidelines in Poland, the recommendations for prenatal diagnostics of our society and the human genetics is from 2021, and there is also a sentence about the screening for preeclampsia, and this is this one: the pregnant woman should be informed about the additional benefits offered by combined tests like the assessment of the risk of preeclampsia and fetal growth restriction. So this is about the use of PAP-A. Of course, the optimal solution in Poland would be an incorporation of the preeclampsia screening into already existing prenatal program of our NHS, this is the NFZ. It would be very simple and effective, but until now we do not have the reimbursement of PLGF, so we have to wait. We hope that it maybe we can get the results, good results in the next future. So in conclusion of my short speech, the screening of preeclampsia is crucial in preventing adverse maternal and fetal outcome, especially when we consider that we have an effective therapy with low dose aspirin. Then the method of screening may vary depending on local protocols and resources. So it would be, of course, optimal to have the PLGF, but not everywhere it's possible. So because it's not reimbursed in many countries, like in Poland, and the screening for preeclampsia is beneficial for the mother and child and should be the part of routine antenatal care. Thank you for your attention.
Thank you very much, Professor, for this very detailed overview on the subject of preeclampsia and the components of screening. We are lucky that we have the Polish Society of Obstetrics and Gynecology that follows so closely the guidelines for, let's say, the Fetal Medicine Foundation, and is very updated in its rules. So I'm very, very glad, and thank you very much for this presentation. From my point of view, it's very important what you said also at the end, that implementing screening for preeclampsia and giving aspirin prevents many maternal and newborn complications. It's not only preeclampsia, but also other adverse outcomes. So
Correct,
this is also
yes.
very important for me.
I agree fully. Thank you.
Professor, we hope that you will join us in the discussion when Professor Nicolaides will join us later. So we are waiting for you, and thanks again for the fantastic presentation.
Thank you very much.